So welcome, Leonard. Go ahead and begin your presentation.
Thank you very much indeed for such a sterling introduction. I love it. I'm going to just learn how to do this. Great. I'm going to speak on an issue very close to my heart. It is obviously with an agenda, and anything that one says about these sort of things obviously is driven by an agenda. And my agenda is that I feel that the power of religion is such that it has avoided dealing with what really happens in people's heads when they are not well, and also in terms of them understanding their existence on this world. So I have read very widely to understand what religion and spirituality is all about. And with all that reading, I eventually came to some understanding that we need to really look at belief systems. So this inspired me to look as broadly as possible to see what it is in man that requires him to formulate some understanding of what he or she is all about. So I'm going to, in my clinical practice, I then wanted to see if I looked at belief systems rather than looking at spirituality or just religion, what would I find? So today, I'm going to look at that, but I'm also going to look at the clinical side. I love the Venn diagram with the biopsychosocial way of examining our patients, and I find that very useful in a day-to-day world. But the part of those Venn diagrams has an intersecting area, which I am trying to get through and it be accepted that that must contain beliefs. Because without understanding, particularly in such a multicultural and multi-ethnic world that we live in, one needs to really look and see what is the patient's belief that is sitting in front of you, so that you can somehow emotionally and culturally join with that person, not that they feel that they are somehow excluded and somehow odd, but that one can really show that one has an interest in their beliefs and what they are actually all about. So why do we do research on this? And that is what Harold is all about, and his group is looking at the whole issue of research into religion, spirituality, and beliefs as they relate to health. We are clinicians. We want to help and improve the quality of life of our patients. That's what we really want to do. And by understanding their beliefs, one is able to respect them in a new way, and one is able to take their beliefs into account when one is dealing with various issues. And particularly so in a multicultural, multi-ethnic society as South Africa is. We Caucasians are really a minority in this African country. And there are many, many beliefs and many, many different ethnicities and cultures, and they are fascinating. They are wonderful to learn about, and they are practically useful in one's clinical practice. So religious, spiritual, or other beliefs may be an important source for coping with illness. And that is what we want to do. We want to help our patients to cope with not only illness, but also with bereavement and other issues. So they play an important role in assisting our patients to have an improved quality of understanding what they're all about and what the trauma is that they are experiencing. Religious or other beliefs may contribute to mental pathology, but this is rare. This is rare. I have not actually seen anybody that has really been driven to mental illness by their religious or other beliefs. That I have not seen. I've seen folie à deux when patients in a relationship share a delusion, but I haven't seen a patient that is driven by a belief system that actually makes them ill. And then we come to my agenda, which is psychiatrists should be aware of the patient's religious, spiritual, or other beliefs. That is really what I'm promoting. I'm wanting our colleagues to really take an interest and read and speak to people about what they actually believe. And we need to understand what function these particular belief systems play in the patient's life. And that is really so important from a clinical point of view. The appreciation by patients when I join and say, I understand what you believe. I understand what you believe, and I respect what you believe. And I think that what you're doing with your belief is actually of benefit to you. So that is my agenda with today's presentation. Psychiatry has taken a huge interest in this whole area, and very important associations issue position statements. And they're all very wonderful, and they all say all the right things, but very rarely do they speak about a broad understanding of beliefs. And we'll go into the whole breadth of beliefs that I experience. So the World Psychiatric Association has a lovely one. I'm not going to go into reading all these things. They're all available for anybody that's interested. The Royal College of Psychiatrists has a position statement on spirituality and religion. Notice spirituality and religion, non-spirituality, religion, and beliefs. The South African Society of Psychiatrists, likewise, has a very powerful statement on the whole issue of spirituality and religion. Again, not specifically relating it to beliefs in a broad context. And that is particularly important, as you'll see, in this African situation. And that is a different thing, because otherwise people feel that if they don't have a religion, then they're in fact not believing anything that's of any value. And that is not the situation, as I'm hoping to demonstrate today. And the American Psychiatric Association, and I really need to be corrected here, I cannot find a position statement. So if someone can send me the position statement of the American Psychiatric Association, I would really, really like to read it. Research groups, well, there are numerous, and Harold is well aware of the wonderful contribution his team, Dalmeda and many other people, are making to actually conducting research. But again, my criticism is that it's researched from a religious and spiritual perspective, and not from a broad belief systems perspective. And I'll be going into that and saying why I feel it should really be belief systems in health. But that's a different issue. I hope to be able to share that with you. The diagnostic formulations, very important. I'll be going into what DSM-5 says. And then with us all being clinicians and having to make a living, there's thankfully a 2021 ICD-10 CM diagnostic code for spiritual and religious counseling. Sorry, someone's got their sound on. I don't know who it is. If I can switch it off, that would be wonderful. That's great. So going through those areas, there's much attention. And of course, there are many, many books looking at religion, many books looking at spirituality, ranging from monotheistic practices to other practices, which I will go into just now. So why is spirituality, religion, and beliefs an issue? Why? And particularly in clinical practice. The medical specialty of psychiatry uses research in the field of neuroscience. We are biologically trained, as opposed to theologists, who are not trained in neuroscience. So we occupy a very specific niche in the whole issue of spirituality and religion. And understanding that from a neuroscience perspective. We are also trained in psychology, the human psychology, which is the important expression of a person's spirituality, religion, and beliefs. That is what psychology does, and it governs many aspects of the person's life, both from an interpersonal point of view, but also with their connection to society and to other people, as we will hear. Medicine is there to improve the quality of life. We're not very good at saving lives. Most people die. We don't seem to make anybody live forever. So medicine is there to improve quality of life. And if spirituality and religion and beliefs improves the quality of life, then that is an area of medicine that needs to have a strong focus. The biology, that connects to the neuroscience, and of course with the psychedelic substances and other measures that we have in terms of special investigations, the understanding of the areas of the brain that are related to the biology of spirituality and religion and beliefs is receiving a great deal of attention. Biochemistry, yes, that is all to do with the biology, obviously, and we know that if we change areas of the biochemistry of the brain, for example, with psilocybin, LSD, and other substances, we can induce spiritual experiences. We can induce spiritual experiences with chemistry. There's also other ways of doing it, for example, with rituals, with dancing, with drums, with noise, with various changes in temperature, et cetera, even lightning can induce a spiritual experience. So it has to do with the biology, biochemistry, and the neuroscience, which is what we are all about. We are not theologians. We don't have to rely on a single text to reach some sort of conclusion about what it's about. We can look and see what is the origin. And the origin of these things is the brain. And psychiatry is what is focused on understanding the brain and our behavior. And then the pharmacology is obviously using medication to assist people to get well. And of course, that's receiving so much attention now with the role of psilocybin and these substances, psychedelic substances, that can induce a spiritual experience. And the consequence of that, the result of that, is in many cases that there are major changes to people's behavior. So again, psychiatry looks at being able to access spiritual areas of the brain, the neurology of the brain, the chemistry of the brain, and lead to some changes that are positive changes in that particular person's life. So again, going back to my agenda, all medical doctors must remain mindful of, and this is what I teach the medical students and to registrars and other doctors, that neuroscience and the biology of the brain has to do with spirituality, religion, and beliefs. The psychology and the functioning of the mind. Psychologists are very often write fantastic texts about the whole issue of the psychology of spirituality, religion, and other beliefs. Medicine and the many illnesses that affect man, we obviously as doctors have to know that and understand that, and that's where the pathology comes in. I'm very grateful to have had exposure to looking at the actual intricacies of pathology and illnesses and how they interact with the person's body in its entirety. Pharmacology, how we can use medication to improve a patient's life, which could also include improving their view of their spiritual being. And then the thing that is really fun, which is looking at culture. And because culture is intimately attached to a person's beliefs, to a person's
I'm
religion.
have my second boost.
Sorry, I couldn't hear that. Spirituality and belief systems. So it really is very important to understand the culture of people. What drives them? What rituals are there that make their life meaningful? And what interconnection with people who are like-minded? That is a very important component of religion and very important component of culture. And living in Africa, where a death of a person has very, very intricate and very clearly laid down rituals that go with the death. And that is part of the culture, it's part of the belief systems, it's part of the religion, and it's part of the spiritual foundation of a whole nation of people, and people with whom I come into contact with every day. So let's just look briefly at some psychiatrists' definition. Michael Trimble wrote a magnificent book called The Soul in the Brain. He's a most remarkable psychiatrist. I have had the pleasure of spending many hours in his company. And The Soul in the Brain, from a psychiatrist's perspective, is a very enlightening book. And he describes religion as the practice and outward expression of spiritual beliefs with its associated activities. And that's what religion does. It has ritual, it has so many things attached to it that make the whole spiritual experience come alive. It's organized into integrated systems of doctrine, and of course dogma, and all the other things that go with it, and of course texts. One should really include texts, doctrine, dogma, and that is what formulates the expression of religion. And it's in institutionalized structures. You only need to have gone to the Vatican to see the magnificence of the structures. They are awe-inspiring. They inspire a sense of spiritual reality to people. I was listening to last week's talk where the whole issue of spiritual experience in structures that are quite bland and uninspiring, how that can in fact remove some of the spiritual component of the experience. But most important is in adherence to a collective community of like-minded believers. Whatever we feel, we like to be with people that speak like us, that think like us, that have a common belief system. That is what makes us very happy as human beings. Being stuck in a world where one is not able to connect to people is a very empty and not a very healthy world. So that was Michael Trimble's definition of religion. Spirituality, as opposed to religion or a belief system, may be defined as a progressive individual or collective inner capacity, consciousness, or awareness of transcendence. Now, the word capacity is really most interesting because if you look at the biochemistry of spirituality and you look at serotonin receptors, there's research produced in Sweden that shows that one can take tissue, brain tissue, and look at the receptor density. And from that receptor density, you can in fact predict if that person is going to be spiritual and religious in their outlook and functioning versus somebody who isn't. There are many people who have no interest in, no energy, no desire to pursue a spiritual path. And then you have other people who will spend their entire life like a monk and pursue this desire to have a spiritual reality in their life. So capacity has a biological component, also obviously has a psychological component, and then with the support of one's community, that will be enhanced. So if you live in a very spiritual or religious community, then that will improve your capacity. Consciousness. I see consciousness as an understanding that we are only here for a very brief period of time. We're aware of the now, but we're also aware that nothing is permanent and that we have to formulate our life in such a way that we are conscious that we are just here for a brief period of time, and we need to make the best of that and understand it as best we can. And that links in to the awareness of transcendence. And of course, this is where monotheistic religions were so strong. They said, yes, there is transcendence, but you will have a permanent place in eternity. And if you're a good person, you'll have a lacquer time, a wonderful time. And if you're not a good person, you're going to really struggle with the hellfires. So transcendence is a huge issue. We see that in the Egyptian writings where you cross the river Styx, and in all other religious writings, the issue of transcendence from this world to the next world is a very strong supporter or inducer of one's pursuit of some spiritual understanding of what the world is all about. This slide is so important because this again goes back to my agenda, that one sees that spiritual and religious beliefs and other beliefs are so fundamental to dealing with people that come into our practice. So monotheism, that's Christianity, Judaism, Islam, Abrahamic monotheistic religions. They are in writings to support it, and very intricate writings and rules and judgments and all sorts of issues that go with monotheism. Pantheism, and in South Africa, we have a huge Hindu population. They have 30,000 gods, 30,000 gods, as opposed to the monotheism, which has one God. So Hinduism, you can have your own personal God, and you can pray to that God to assist you and improve the quality of your life. And we know the huge efforts that the Hindu people make to pursue their belief system. Animism, and this is what is so neglected in the African situation. The fundamental belief of Africans, of Black Africans, before the colonialists arrived, that includes my parents, they had a very healthy, functioning animistic belief system. They had contact with their ancestors. They had rituals that went with it. When I grew up as a child, we knew that people were buried where the cattle kraal. A kraal is where the cattle are kept. That is where the person was buried. End of story. And there was then the ancestors of that particular person could be contacted by a traditional healer, Isangoma as it's called, or an Inyanga, and that made the person feel that their life had a meaning. So when I speak to my Black African patients, I will understand that they will say, yes, I'm a Christian, but when you look at it deeper, they hold strong animistic beliefs. Before they come and see me, they will have gone to see a traditional healer to find out what is actually happening to this person that is having these strange ideas, strange behavior, whatever. Then we come to non-theism. Buddhism has no God. So Buddhism focuses on the person themselves to improve their spiritual quality, the quality of their spiritual life. But it becomes you as an individual is responsible for being the best person that you can be. Then atheism, which is followed by many, many people, a belief that no God exists. It's a little bit thin. I think that that really is just one small area of anybody's existential thinking, but the atheism is often professed as being a particular belief. Then we come to anti-theism. That's the Bright Movement, Dawkins and company. And then they have a wonderful church called the Flying Spaghetti Monster Church, which is openly anti-theistic in its expression. But then there are many, many more religions: Shintoists, Baha'is, Spiritists, etc., etc. And you can see there on the side, I've put in the calculated percentage of the world population that follows all these other religions. So if a Jainian comes to see me, I would need to understand that Jainism is a particular form of Hinduism and that it has special components to it. So again, emphasizing this agenda of mine to understand our patients as not having just a particular accepted belief system, but that there are multiple belief systems out there, and that one needs to take an interest and explore them further and come to some understanding what that is all about. So this is really an important slide. So now we come to try to define what is a belief system. So Jonathan Glover is not a psychiatrist, he's a philosopher. A belief system is a set of mutually supportive beliefs. They support what I believe. I believe that there are fairies that come and bathe in my fish pond every night, and I'm quite convinced that there are little fairies coming to my house every night. And it's supported by my experiencing that there are some there. That is real, it's not important. That is a supportive belief. The beliefs may be religious, philosophical, ideological, or a combination of these. So again, focusing not on spirituality or religion, but focusing on belief systems, which sets the door open for seeing things on a much broader perspective than just looking at a particular religion or a particular spiritual path. So what are some examples of belief systems? Well, spiritual beliefs are enhanced by meditation. That is what there's Christian meditation, there's Buddhist meditation, and many other forms of meditation. Contemplation, and that is what monks were, contemplative monks. They are a particular group of people who improve their spiritual experience by being in a state of contemplation. And of course, we can induce it artificially with psychedelics. So spiritual beliefs can be enhanced with psychedelics and other forms of practice. Philosophical beliefs, like Stoicism, the old Greeks, and existentialism from Kierkegaard. He was the son of a Lutheran minister, which my parents were also Lutherans, and he broadened also his understanding of himself and his world in his existentialist writings. Moral beliefs, humanistic and a sense of right and wrong. Won't mention where some moral beliefs have fallen flat with all the ongoing issues we're dealing with in the world. Supernatural beliefs, and there are wonderful things on pigs do fly and other issues where they are very, very difficult to understand supernatural beliefs. Belief in science, and I suppose I must confess that in terms of my own belief system, I am a data-driven scientist, and I believe in evolution. I believe in the epigenetics. I believe in the new understanding of biology and the way in which our brains are evolving over time. And that also changes our belief system. And cultural beliefs. not emphasized enough. Rituals, death issues, and burials are very much part of the cultural beliefs and rituals that enrich the life of the people in Africa, particularly, where they are such emphasis on making sure that these rituals are kept as best they can. So going back to the DSM-5. So DSM-5 has designated a code for the diagnosis of issues related to spirituality and religion. There's a code. The whole issue, the whole thorny issue of spirituality and religion, if you want to get people really excited and upset, you say all sorts of dastardly things about their spiritual beliefs or their religion. So the DSM-5 very cleverly has watered it all down to be designated as culture. So the DSM-5 designated code thus reads, this category can be used when the focus of clinical attention is a religious or spiritual problem. DSM therefore assumes that religion is a part of culture, and the inclusion of religion and or spirituality in psychotherapy may belong to the patient's preferences. Absolutely. And that is what we as clinicians need to have a deeper understanding. And that again is part of my agenda in putting this particular presentation together. So when we are seeing a patient, we look at the biology, their genetics, substance abuse, trauma, physical trauma, whatever, and we do the biological side absolutely beautifully. Then we look at the psychology, the personality of the person, the experiences that the person has had from the birth canal to the time when they are being seen by the psychiatrist or the psychologist. Someone's, I need to unmute. And then these social aspects, which are very, very important. And many of our patients present with particularly unmanageable social situations, and that we give a great deal of attention to, from work to interpersonal, to family, to relationships, and all those good things. So a biopsychosocial assessment of a patient is the fundamental. But there's no area in this wonderful Venn diagram for beliefs. And I'm proposing that the intersection of the Venn diagram be designated to beliefs. And that'll make doctors more sensitive, more aware, more desirous to actually look at persons' beliefs and the way those beliefs can enhance the person's quality of life and management of any emotional or other difficulties they may be experiencing. That is the fundamental message today. So what is my hope? My hope is that it will make clinicians aware of the huge diversity of beliefs held by our patients. And not only the diversity, but the fascination, the interest, the learning about one's environment, the people that one comes into contact with, taking some time off to really understand what their beliefs are all about. Looking at beliefs will encourage clinicians to want to ask questions about beliefs, spiritual paths, and religion. And the joy that I see in my patients when I show an interest. Oh, you are a Jehovah's Witness. Tell me more about what is the dogma and doctrine of your particular belief system. Oh, you're a Muslim. I want to understand, and I'm investigating at the moment, the whole issue of gender separation in Islam. And it's a most interesting area to explore and to understand that when one is seeing a Muslim female, for example. We'll make the question, tell me more about your belief in a routine inquiry. Now I'm coming to that. So I will ask my patients, tell me, what do you believe in? and the responses are really quite fascinating. We will do away with questions like, are you a Christian? Are you a Hindu? Are you a Muslim? Because people feel that if they are something else, they're either weird, or they're out of step, or they are not a good person. And so when I see these forms from various administrative agencies, which I'll not say anymore, where you have to tick, are you a Christian? Are you a Muslim? Are you a Hindu? I really find that an intrusion on my being as a person. It should not be included in questionnaires at all. And will make us more aware of the many beliefs held by our patients. And patients can have many beliefs, not just one belief, but have many beliefs. And many of these beliefs will play a role in the way in which the patient presents and the way in which the patient hopes to be healed. Now, there's the very detailed recommended inquiry. My gosh, it is full of so many questions. This is now a quote from the recommended inquiry. Do you consider yourself a religious or spiritual person, or neither? If religious or spiritual, ask, explain to me what is meant by that. Well, most people struggle to understand what the difference is between spirituality and religion. If neither religious nor spiritual, ask, was this always so? If no, ask, when did that change and why? Well, I might have been exposed, for example, to lightning or to psilocybin or some traumatic event or something. Do you have any religious or spiritual beliefs that provide comfort? Oh, that is such an important sentence, because that is one of the things that religion does do. It provides comfort. If no, ask, is there a particular reason why beliefs do not provide comfort? That's a difficult question, and I don't think most people are about to answer that in any detail. And there's a whole range of things that are part of a more in-depth inquiry that then follows. I want to be radical and suggest a more open clinical question, taking into account the time constraints of a routine biopsychosocial clinical history. You've got 50 minutes, you've got an hour, you're lucky if you've got an hour and a quarter with a patient, and one can't spend too much time just on their spiritual and religious beliefs. So I want to say that we should just summarize it in one thing. What do you believe in? And if that is an issue for the patient, that sentence, that open sentence, will open a cascade of verbiage from the person describing what they believe in and how they are relating to their beliefs and how they see their particular illness or their particular problem and how that relates to their beliefs. I'm going to now go back to Africa. This is a lovely picture of an izangoma. I have attended with one of my colleagues from Sweden, in fact, the traditional healer ceremony. And the traditional healer ceremony has all the right attire. It has the wonderful beat of drum, as you can see on the picture that I've taken. You can almost feel from the picture, the noise from the drum and how that creates an environment for the particular patient that has come to see this traditional healer. And izangoma is like a psychologist, but a spiritual psychologist, because it's all very much tied up with spirituality. And the person will come and they will have what's called an izivumisa, where the traditional healer will say, I can see your heart is sore. And then the person will say, ngiyavuma, I agree with that. But it's all done in an environment that is conducive to a spiritual and healing ritual and experience. So to end the little story of why belief systems, rather than spirituality and religion, is relevant to the South African reality. The picture that you see, this particular thorn, from a tree called a buffalo thorn tree. And it has two thorns, and they're both very sharp, let me tell you, I have experienced them. The long thorn and the short thorn. And King Shaga, who had very brave warriors, and we only need to look at Rorke's Drift, where the army of the King Shaga defeated the English army. They were very strongly attached to their particular animistic belief system. And King Shaga said, the long thorn is to keep you strong, to keep you committed to our people. The short thorn is that you don't forget what you believe. That was King Shaga so many years ago, emphasizing that the person's beliefs, commitment, feeling of connection, feeling of some spiritual meaning to their life would not be forgotten in this lovely, lovely African plant. So with those few words, I will end, and I'm very happy to take questions, and I will be interested to hear what people experience and think about what I have just said.
Okay, so any of you have any questions, feel free to just break in here and ask your question. I believe that Bruce has his hand up. I'm not sure if he intended it, but Bruce?
No, he's off the microphone.
No, I didn't have my hand up.
Bruce
Are there no
McCallum.
questions?
Yeah. Any questions? Please feel free to ask Leonard.
I think that was an accidental push. Sorry.
Okay, no problem.
Hi, my name is Christine. Can you hear me?
Yes, we can hear you.
Okay.
Yes.
I have a question when talking to people about patients. I'm a psychiatric nurse practitioner in New York State in the USA. When talking to people about their spiritual beliefs, how do you approach a spiritual belief that could be harmful if they believe in self-harm or cutting or things like that? How do you address that from a provider point of view? Do you have any thoughts on that?
Well, I have not experienced that in particular, but we have a thing called a conflict between a traditional healer and a Western medical practitioner. And when there is something that I would feel would be harmful, for example, if the person only goes to the traditional healer and actually requires a dopamine blocker, then I call in the traditional healer. And we have the traditional healer. I've got lovely pictures to show you because they're beautifully dressed with all sorts of wonderful things from gallbladders and skins and all sorts of things. And then we work with them. We say, yes, we want you to make contact with the ancestor, but we also want to make you, the traditional healer, responsible for making sure that the patient takes his medication, or as in South Africa very often, is a depot injection once every 6 weeks. So we work with the traditional healer so that the belief system of the patient is looked after, but we make sure that they're not harmed. So what I hear from your question is that when you can see somebody is pursuing a particular belief that could be harmful, one needs to not do a whole confrontation session, but rather to see if there's anybody like-minded and bring them into a session and look and see how one can still respect the patient, but also ensure that the patient is not harmed by their particular belief system.
Thank you. I appreciate that. Thank you for the talk. It was wonderful.
Oh, that's nice. Thank you. I appreciate you liking it. Enjoy
Francis,
it. Yeah.
Francis Liu has a question. Francis?
Yes, I just thank you very much for that talk. I just am putting into the chat information about the cultural formulation interview supplementary module on religion, spirituality, and moral traditions. That provides a list of 18 questions that can be asked to assess religious and spiritual beliefs as presented today. And you can I'll put it in the chat, the way you can access this supplementary module.
Great, thank you, Francis. That would be terrific for all of us. Other questions?
Harold, can I just answer that?
Sure.
I understand that if one wants to really explore things in great depth, I think a question module is very useful. But in Africa, the reality is that there is not the time. I can have 20 patients sitting on benches outside my office from 6 o'clock in the morning. There is not the time to invest in dealing with great long questionnaires. It's just not possible. So a simple question is explorative and lets the person feel that you are interested in and supportive of their particular belief system.
Okay, great. So let's see, we have some people unmuted. Pat, do you want to ask a question? Pat Stearns?
Oh, wait, where am I?
There you go.
Okay.
You're right here.
I got on late, so I don't have a question at this time.
Okay, sounds fine. Any other questions on this fascinating topic?
Yeah, I have a question. I'm Suhasini. I'm speaking from India. Basically, it has been my personal experience that in a hospital setting, time is a very big factor, especially when it's an OPD or when you're treating somebody as an outpatient basis. So what I feel, what is more practical is just identify and and refer to a suitable whichever belief system the individual is following, refer to them to a suitable institution or wherever they are aligned with whom they are associated with them, and that really works wonderfully. I recently relocated from one city to a different city, and then I had an opportunity to come across a patient who was suffering with alcohol dependence syndrome, and he was having alcohol. Actually, it is multiple substance use disorder, and he had been treated several times, and he had relapses. But I do not know what inspired him, and he had come to me, and then I just inquiry, just as you say, that you inquire into an individual's belief system, and then the answer comes from the individual only, and we facilitate him. And I think it is just the spirituality that has inspired him to give up alcohol. He gave up alcohol 2 months back. He gave up alcohol. He had withdrawal also. He had to be treated. After the treatment, then he was associated with the religious practices, and he was absolutely fine for 3 months. But due to some reason, he was cut off, and then again he had a relapse. And after that, again, when he was reassociated with the religious system, he could realize the pleasure or the benefit that he derives with the religious practices, and he's totally convinced now that this is the thing that he has to take.
Sorry, I don't quite hear your question. Tell me, what is your question? What is your question?
Yeah, my question is that that I had already told you before, that in an outpatient setting, you only identify to whichever what is the belief system of the individual, and the strength of the belief basically, and refer the individual to an appropriate
Sorry, I don't quite understand your question. What do you want me to reply to? What is your question?
Okay, my question is that a physician, a doctor cannot delve in depth with the.
No, that's perfectly true. And we both work in an environment where time is a constraint. But having an open-ended question is a good idea. Thank you very much for your question.
Yes.
Very good. Who is next? I see that Meba Kanda has her hand up, or his hand up. Meba.
Yeah, thank you very much. I'm coming from South Africa. Thank you, Leonard, for a very beautiful presentation. Yes, I do support your suggestion of having exploratory question in the setting where we have limited time and energy, actually, with many clients and so on. But I would like to say it's also very important for us, as much as you have raised it throughout your presentation, to also have an observation, to have a keen interest in observing the client. Sometimes our client, when they come in the clinic or the practice, the way they dress, the way they talk, the way they greet you, they can as well communicate clearly their belief system. And besides the clinic, when we are outside, it's very important for us to be interested in the context, to understand the people around. That would facilitate the practice. Thank you.
Very much. That's a lovely comment. Thank you. Lovely. That's nice.
Excellent. Let's see. There are some that are unmuted now. Are there questions that you would like to ask our speaker? Dr. Brandsma?
No, I just, sorry, I just joined in. I missed the first hour, so.
Oh, okay. That's all right. No problem. Anybody else have a question? We have about 1 minute before 1 o'clock, and I want to respect everyone's time. This has been such a fascinating presentation. Anyone have any questions here? 1 or 2 questions we have time for. Feel free to unmute yourself and go ahead and ask your question.
And even a critical comment would be lovely, saying this is complete nonsense, you don't agree with this, or something to that effect. So criticism and that sort of thing is absolutely fine. I'm robust.
My name is Iris Barrett, and I am a minister and lay counselor in North Carolina here in the US. I have individuals that come to our outreach ministry, and they say they are Christians, and I thank you for your help. I make certain assumptions, but I have no idea their belief system, although they place themselves under a particular umbrella. Can you assist in letting me know if you've ever encountered individuals that they're calling themselves something, but when you ask them belief systems, they really cannot give you clear answers?
Well, this is a Pandora's box, and I can say many things about this whole thing of having a label versus what people actually believe. So if you look at, for example, the statistics on Christians who believe in the resurrection, you'll be frightened to hear the percentage of people who actually don't believe in the resurrection at all. So having a label is one thing. Having an actual belief in what that label contains is a very different issue. And that is the area one will explore when one has time with a patient, gets to know a patient, to see what they actually believe is possible and what they actually believe is in fact not true. So yes, you opened up Pandora's box. Thank you.
You've been very helpful. Thank you.
Okay, we're unfortunately have to stop now, but Leonard, thank you for a brilliant presentation, and thank you all for participating and asking your questions. God bless you all, and we'll see you maybe next month too. Bye-bye.
Thank you. Bye-bye.
Thank you.